Ladies and gentlemen, esteemed guests and distinguished speakers, hello and welcome to yet another exciting webinar in the series of webinars brought to you by 3D Organon. Today is a momentous occasion, a celebration of innovation and progress in healthcare and medical education. Allow me to introduce myself. I'm Theo Zirianis, the Chief Customer Officer at 3D Organon, and as the coordinator of this webinar today, I'm honored to welcome you to VR in clinical anatomy teaching. Before we embark on this enlightening journey, I'll bring to you breaking news. Today, we are witnessing the dawn of a new era in medical and healthcare education with the introduction of the new 3D Organon. This revolutionary tool promises to redefine the way we perceive and understand anatomy. Immerse yourself in cutting-edge features from blazing performance to redesigned visuals that offer unparalleled realism. Explore organ mapping, unleash the power of the explosion tool, and streamline your workflow with enhanced performance tools. With the new 3D Organon, you unlock your potential to master effective and engaging lecture delivery and also deliver unparalleled instructions armed with powerful tools designed to enhance learning outcomes. Today, as we convene to explore VR in clinical anatomy teaching, let us celebrate the unveiling of the new 3D Organon, a testament to our commitment to innovation and excellence in healthcare education. It is truly an honor to have with us our esteemed special guest speakers. First, we have Dr. Sharmila Saran Rajendran, a clinical anatomist from the Department of Physiology, Anatomy and Genetics at the University of Oxford. Dr. Rajendran's expertise in anatomy and medical education is unparalleled, and we are privileged to have her share her insights with us today. Joining Dr. Rajendran is Dr. Rumyana Smilevska, a HPB and Transplant Surgeon, clinical lecturer and researcher at the Oxford Transplant Centre, also from the University of Oxford. Dr. Smilevska's expertise in surgery and medical education brings a unique perspective to our discussion, and we eagerly anticipate her valuable contributions. Together, Dr. Rajendran and Dr. Smilevska will illuminate the transformative potential of virtual reality in clinical anatomy teaching, offering invaluable insights drawn from their experiences and expertise. So without any further ado, please join us in welcoming Dr. Sharmila Saran Rajendran and Dr. Rumyana Smilevska. Please. We take the floor,
Hello,
please.
everyone. Thank you, Tara. Thank you for the introduction. Just we're going to share the Hello, everyone. Welcome you all to this webinar. We are so excited to meet you all in this virtual platform. And myself, Sharmila Rajendran, I'm a clinical anatomist from Department of Physiology, Anatomy and Genetics. And over to Rumi.
And I'm Rumi. I'm a hepatobiliary and transplant surgeon and a clinical lecturer at Oxford University. And today we give you this webinar on VR in clinical anatomy teaching.
We see this is a great platform where we're going to share our journey with the 3D Organon, and we are going to give journey with VR. Here we go. Sorry for the inconvenience, just a minute. There. So our journey with the 3D Organon started in
And we cannot help you. We cannot hear you, sorry.
With learning and digital IT services. So before we introduced the 3D Organon with the students, and we have evaluated so many parameters, and we took one step at a time. So we looked at range of various headsets, start from Oculus One, Two, Oculus Rift, HTC, and we looked at whether it's comfortable for both students and staff, whether it has adjustable straps or the knob to fit in the head circumference, or it has adjustable lenses, or the controllers are comfortable to hold and manipulate, whether it is lightweighted. And moreover, we looked into the how the haptic and visual feedback from the headsets. And we are also evaluating which one to go for, standalone and PC powered. And if you're going for a PC powered one, we would suggest you to look at the system requirements recommended by the 3D Organon. Look for the graphics card that is listed in the SteamVR. We also looked at the other aspects, majorly the health and safety. We run through the safety sheets provided by the hardware. And in relation to here, before our VR session with our students, we give them a health and safety information, what is indicated in the safety sheet, as well as we also prompt our experiences as well. And thereby students will get aware of what is about the session right before they come for the VR teaching and learning. And we also thought about where we can utilize this VR, whether we should fit in the small seminar room or on large scale, or in the digital lab with IT services. And we also thought about other safety measures to consider, like whether it would be feasible to do in a stationary boundary or a room scale boundary. And we would highly recommend to when you start, we started with the stationary boundary for safety reasons. Of course, with the room scale, if you have enough room space, you have a team to watch over so that they don't bump each other. However, with the pass-through options now, you can overcome any difficulty with the room scale. So, and then we chose the standalone because it was more affordable, and IT services supported us to providing more headsets. And initially we had like 10 headsets to start up with the initial testing. Moving on, we also evaluated a range of softwares. We see the how the range of content is given in the application. We also looked at the accuracy of the anatomical details. We also looked at what are the creative elements in the app. For instance, in 3D Organon, it has like a painting. You can create a bony spur, and it has a very good annotations and the descriptive panel. And those elements added more value to our evaluation. We also checked whether it is too complicated to study the 3D model. How about the clarity? How far we can zoom in, zoom out? We also looked at the other elements like the microscopic anatomy and the contents of the neuroanatomy as well. And we also checked how user-friendly the app, especially how it is compatible with the headsets. We also checked how it is easy to manipulate the 3D model, whether to move forward or backward or to rotate, so and so. And we also checked how easy to assess between the systems. And we also looked at the visual graphic and the simulation given by the application. And other features also, like that are the like assessment aspects. Overall, as such, our aim is to look how the hardware or software fits together for student-centered approach, including neurodivergent students, whether it could facilitate the seamless processing and navigation, whether it enhances the anatomy learning experiences, and then it promotes self-learning, whether it adapts to the different learning environment. More importantly, what we looked is about how the VR we can make it very inclusive, where we can bring more peer collaboration and interaction. Having said that, we have put up some few data across 2 years. So this side is this from year one medicine students, and other side is this from the biomedical science year one students. So overall, from the year one medicine, graduate in medicine, and the biomedical students, they experience a very immersive learning with the VR anatomy. And when we looked back our results from the first year medical students, either from the last year or from the current year, which system did the students explore most, or which system they wanted to explore more? Most of them, they wanted like go for musculoskeletal system, followed by the cardiovascular system, musculoskeletal and the cardiovascular. We thought musculoskeletal because maybe because the academic year starts with the musculoskeletal anatomy. So given that result, we are planning to reinforce, to integrate the VR sessions at the early phase of the academic year. And interestingly, we wanted to see how the biomedical students see the VR anatomy in learning. Given that the BM1 and BMS1, the anatomy content of very light to the BMS1, but still the students experienced the students has experienced the better understanding of the organization of the body. And it also helped them to ability to identify the required structures, which is great. And we also looked at the challenges, like students often mention they have difficulty to use the headset, especially when they have glasses. However, with the MetaPro, from our experiences, with the MetaPro, students are not mentioning about the difficulty with the MetaPro device. And some of the students, they also mentioned they find it blurring, especially the students who have the glasses, they find it. So that's why you see that variation between agree and disagreement here. And in terms of the time, with our experiences, we set a standard timing for VR teaching or VR session. So we set like about 25 to 30 minutes as a maximum. So to avoid any eye tiredness or to any sickness followed by it. But most of the students, they love to expand more than 30 minutes, but we suggest them to take a break to continue further. And students are finding it very easy with the headset, controllers, or application, and they don't have any fear of damaging any of the equipments. So this is a general data from our experiences. So overall, as you see, this iterative process where we evaluated, where we designed, we tested, and then we applied in practicals, and then we learned a lot. We are here to find where we can improvise, where we can refine further, and then we re-evaluate, and then we'll redesign. So this is a process that we always adapt to our learning system. So we would like to hear your thoughts on how you use VR. So if you could scan the QR code, which is given in the other slide, and we will able to continue our conversation in the chat platform. Thank you. We love to hear, we are from south of UK. We love to hear from where you're from. You can say hello to us. So these are started at the very introduction, but we want to know where you're all from because we are connecting virtually.
Yeah, from retreat.
Hello. We're coming up in. Hi, Ahmed. Nice to see you. Wow. Hello, Patrick.
Only three have written in the
Chat.
chat.
Okay, great.
Okay, well, once we complete the presentation part of the webinar, then we'll be conducting a Q&A part, allowing our guests, our participants, to actually ask their questions,
Yeah.
allowing us to address any of their concerns and so forth. So, great. Okay.
We're just going to the next slide.
Yes.
Just stop. Stop. So we want to know, have you been incorporating VR in your institution? Have you been trying to or planning to see?
They're right here.
Not yet. Okay. Thank you. We're going moving forward so we will answer at the end again. We can discuss this. Great. Great. So we have described our evaluation aspects. So in case if you have a plan, so what elements or parameters that you would check in terms of our hardware or software? Okay. Thank you. We'll go back. You can go back to the slide. No problem.
Organon.
Yeah. Perfect. Yeah. We want to hear from your perspective, which body system or region you would highly recommend VR, or you may find, okay, this system definitely need VR support. Exactly. I always often thought about having the corticospinal tracts or, any spinal tracts to see in the neuroanatomy aspects. Do you find any challenge? Do you think about when you integrate the VR in your teaching, you might think that this might be challenge for us or challenge for you? Great. Thank you very much. It's wonderful to know your thoughts and your perspective aspect as well. Convenience. Thank you. We'll just go back to the slide. Thank you so much for sharing your views on that. It's good to know about this. So given that 2 years of our effort, now Medical Science Division is supporting our project based on utilizing the smart board and the virtual reality. And we also utilize various digital tools in anatomy education. So this is one of the poster we had during the last Teaching and Learning Symposium conducted by CTL, Centre of Teaching and Learning at University of Oxford. And moving forward, in this year, we've been shortlisted for the Vice Chancellor's Award, where we utilize a lot of digital tools, including the VR with the 3D Organon. So we have highlighted how inclusively we can transform the VR education. And we are setting a tragedy pathway of the digital transformation with Oxford Principle, how to complement with the conventional learning. So together, together, we are imagining how Oxford University's culture and process and technology will adapt in the digital era or age. And very recently, couple of our graduate entry students involved in the participating in the boat race in Oxford and Cambridge, where 3D Organon has been telecasted in the BBC. That's about a short journey of our VR with 3D Organon. Now I'm over to Rumi, and she will cover the clinical anatomy aspects. Thank you.
Yeah, so thank you, everybody. So I will present, give a small, short overview of how we conduct one of our sessions of clinical anatomy, and specifically on the arterial supply to the gastrointestinal tract. So if we go on the up and we select the cardiovascular system, which represented here with heart, on the second page, so it's the first page, on the second page, we'll find a very nice platform on the mesenteric arteries. So if we select that, we'll be able, if we look to the right, actually it's the center screen, we'll be able to see the model. And if we remove the bowel, the stomach, and the pancreas, we'll be able to have a nice overview of the abdominal aorta, which will start at the level of T12 at the aortic hiatus. And we can see, sorry, so if we remove all the structures, we'll be able to see how the abdominal aorta starts at level T12 at the aortic hiatus under the median arcuate ligament. And we'll have three anterior branches that we'll have a closer look. This is the celiac trunk, the superior mesenteric artery, SMA, and the inferior mesenteric artery, IMA. So we can observe here the important relationship of the SMA and the third part of the duodenum, that we'll see the clinical importance of this later on. And if we remove this duodenum, we'll be able to have a closer look at the whole of the aorta. And inferiorly, we can see the third and anterior branch of the aorta, which is the IMA, the inferior mesenteric artery. So now we have a closer look at the celiac trunk, which will give blood supply to the derivatives of the foregut. And we can see the three major branches, so the three branches of the celiac trunk. If we go closer, we'll see the left gastric artery, which will give some esophageal branches for the abdominal esophagus. And then we'll have a trajectory and we will anastomose and the lesser curvature of the stomach, we anastomose with the right gastric artery. Then we'll see the second branch, which is the splenic artery, which will give a dorsal pancreatic artery at this level, and then we'll have a trajectory further to the left to give the left gastroepiploic artery, and the left gastroepiploic artery will anastomose with the right gastroepiploic artery at the greater curvature of the stomach. It will give as well short gastrics to give blood supply to the fundus of the stomach, and will give further splenic arteries for the splenic ileum to give blood supply to the spleen. And we can have a look at the third branch of the celiac trunk, which is the common hepatic artery. So if we remove the common hepatic duct, and we need to remove as well the right and left hepatic ducts. So here we have the right and the left hepatic bile duct. So we'll be able to see the whole trajectory of the common hepatic artery, which will give a right gastric artery that will anastomose with the left gastric and the lesser curvature of the stomach. Then it will give the gastroduodenal artery, so the GDA. It will give the right gastroepiploic artery that will anastomose with the left gastroepiploic artery at the greater curvature of the stomach. And it will also give the superior pancreatoduodenal arteries for the blood supply of the pancreas and the proximal duodenal proximal to the major duodenal papilla, which is the boundary between the foregut and the midgut structures. And after the common hepatic artery gives the GDA, it will change its name and it will become the hepatic artery proper, which will bifurcate into right and left hepatic arteries to give blood supply, arterial blood supply, to the liver. So now if we'll move distally into the aorta to see the second anterior branch of the abdominal aorta, which is the superior mesenteric artery. So the superior mesenteric artery will give a branch. First branch is the inferior pancreatoduodenal arteries, and then we'll give numerous jejunal and ileal branches that here have been cut in order to be able to visualize the branch of the AMA. And then we'll give the ileocolic artery, which will have this trajectory towards the right iliac fossa, when it will give blood supply to the terminal ileum, the cecum, and part of the ascending colon. And it will have a specific artery terminal branch that's called the appendicular artery that will give blood supply to the appendix. The next branch of the SMA is the right colic artery that we'll be able to see here. So here is the right colic artery. It will give blood supply to the ascending colon and part of the hepatic flexure of the colon. And the next branch of the SMA is the middle colic artery. So the middle colic artery will give blood supply to the right flexure, so-called hepatic flexure of the colon, and the proximal 2/3 of the transverse colon, giving this the boundary between the midgut and the hindgut structures. And now we'll see the branches of the AMA. So the AMA will have its origin at the level of L3 and will, if we click actually on the structures themselves, we'll be able to see, if we look towards the right, we'll be able to see information, short information about the structure. So here we have information about the inferior mesenteric artery. So the AMA will give blood supply to the hindgut structures. And if we click on the branches themselves, so the first branch will be the left colic artery that will give blood supply to the distal third of the transverse colon and the descending colon. And distally, we'll see that there are 2 to 4 usually sigmoid arteries that will give blood supply to the sigmoid. Here they are. And if we remove this part of the sigmoid, we'll be able to see as well the terminal branch of the AMA, which is the superior rectal artery. So with this knowledge, we'll be able to discuss two clinical syndromes. So the first is so-called median arcuate ligament syndrome. So we saw that normally the diaphragmatic crura will pass superiorly to the origin of the celiac trunk, both at the level of T12. And if the diaphragmatic crura compresses the origin of the celiac trunk, this gives the celiac axis syndrome, also called celiac artery compression syndrome, or for those of you who like eponyms, these are called also Dunbar syndrome or Herjoa-Marabo syndrome, these names of the radiologists and surgeons that describe the syndrome. And the patients will refer chronic epigastric pain, usually postprandial, which means after the meals. They will present then nausea, vomiting, and weight loss. In the literature, this syndrome is more a diagnosis of exclusion, but the gold standard to diagnose it is a CT angiography or conventional radiography, when we'll be able to see this focal narrowing of the proximal origin of the celiac trunk, which is this called hooked or J appearance, and we will be able to see poststenotic dilatation, and importantly, absence of atherosclerosis or other causes of stenosis of the celiac trunk. And the treatment is surgical, and it consists of decompression, so dividing of the median arcuate ligament, and it's usually done laparoscopically. So the first clinical case, we have this 35-year-old male who presents with recurrent postprandial chronic epigastric pain, and on the CT scan, we can observe on the axial cuts here, there is a thickening of the median arcuate ligament, so of the crura of the diaphragm, and it's actually on the level of the origin of the celiac trunk. And on the sagittal cuts, we can observe this, that the radiologist grabbed this hooked image or J image of the origin of the celiac trunk, and this mild poststenotic dilatation. So the treatment indicated for this patient is a laparoscopic decompression of the median arcuate ligament. I don't have any copyright on this. This is taken from Radiopedia, because during my practice, I've never seen the median arcuate ligament syndrome, but I have seen the second syndrome that we will discuss. So it's the superior mesenteric artery syndrome, also called Wilkes syndrome. And this is where this happens when the duodenum, the third part of the duodenum, is compressed between the SMA and the aorta. In normal circumstances, we have a fatty tissue path surrounding the SMA, which allows the SMA to give an important angle, usually bigger than 25 degrees, so that the duodenum can have its peristalsis and its movements freely. But what happens if, with weight loss, this fatty tissue path surrounding the SMA is lost? So we see that there is a narrowing the angle. This is called the aortomesenteric angle, which is less than 25 degrees. And we can also measure the aortomesenteric distance, which is decreased in less than 10 millimeters. When this happens, the duodenum is compressed between the SMA and the aorta, and we can observe a dilatation of the proximal duodenum and the stomach. So patients usually refer mesogastric pain, bloating, distension, nausea, vomiting, and this leads to weight loss, which actually aggravates this syndrome. The treatment is usually firstly medically or conservative with nutritional support, and when this fails, surgery is indicated. We have 3 procedures for the SMA syndrome. The first is so-called strong procedure, or the duodenal derotation, when we liberate the ligament of Treitz so that the duodenum is mechanically liberated from this compression. The second procedure is the gastrojejunectomy, where we perform anastomosis between the stomach and a loop of the bowel of the jejunum to bypass the compression of the third part of the duodenum. And the most frequently performed procedure is the duodenojejunectomy, when we anastomose the proximal duodenum, proximal to the compression of the SMA, with a loop of the jejunum. So this is the first case of a 58-year-old female patient with congenital learning difficulties that presented with 2 years of postprandial bloating, nausea, vomiting, vague abdominal pain, and 20 kilograms of weight loss. So the CT evidence here, as you can see, a very severe gastric distension, so that the stomach is occupying the abdominal and the pelvic cavity. The orthomesenteric angle was measured at 9 degrees, so really decreased orthomesenteric angle, and the orthomesenteric distance was of 4 millimeters as well, very, very small orthomesenteric distance. So initially, conservative treatment was initiated with nasojejunal feeding and percutaneous endoscopic gastrostomy, but this was ineffective, so she was referred to surgery, and the duodenojejunectomy was performed, and she was discharged on the 7th day postoperatively with no complications, and in the follow-up, she's gaining weight accordingly. And the second case that I've seen in my practice is a 23-year-old female patient with no relevant medical history that referred unspecific abdominal pain, nausea, vomiting, and 10 kilograms of weight loss during the last 3 years. So she had an extensive study by the gastroenterologist, including the CT scan, which showed this decrease of the orthomesenteric distance of 8 millimeters and orthomesenteric angle of 18 degrees and distended stomach, but much less distended than the first case. So similarly, initially, a medical conservative treatment was started, but after its failure, she was referred to surgery and laparoscopic duodenojejunectomy was performed, and she was discharged home 6 days after the operation with no complications. Thank you very much for your attention, and we are happy to take any questions from you.
That's wonderful. We'll take a few seconds to give Dr. Rajendran and Dr. Smilevska a chance to catch their breath back before we actually start the Q&A part. This is a good opportunity also, before we actually enter the Q&A part, it's a good opportunity, and it's important to stipulate that none of our guest speakers receive any financial reward or endorsement from 3D Organon for their priceless participation and contribution to our webinars. Okay, I think we can safely say we go into the Q&A part. So we'll just have a start looking at the questions. Oksana is greeting us from the Ukraine with no specific question yet. Oh, here we go. Here's some questions now. Where do we start? Where do we start? Nathan. Hello, Nathan. Nathan Jebet is asking, are students tested in VR or on donors or with paper quizzes? I'll let one of our esteemed guests answer that question. Are students tested in VR or on donors or with paper quizzes?
Currently, they are tested with paper quizzes, or paper, or also on the computer, in a computer lab. Not yet in VR, maybe in the future.
Okay.
You mean to include the assessment? What are we considering assessment using VR?
Yes.
Not yet. Not yet.
Yes. It's a good opportunity to actually inform our guests that in the new 3D Organon Anatomy solution, with this year's edition, we will be introducing the brand new 3D Organon assessment module, allowing the educator, the faculty, the department to actually have control over the setting, the defining of questions for your assessment process. That's something that we're finalizing, and we're very excited. We cannot wait for this to be actually officially announced also. So Al-Tayyeb is asking, Ahmed, hello, Ahmed is asking, have you assessed the student retention following VR compared to before?
Hi, Ahmed. Thank you for your question. So we assessed in a small cohort group for the biomedical sciences. Yes, VR is shown a very good feedback from the students and a very good score as well. However, what we see in our University of Oxford is that since Oxford is more rooted to history and the anatomy teaching, so we aim to provide the VR as a complementary tool for the students rather than like necessary to attend the VR sessions as well. So following with, I think, see the next question where Victoria asked about the similar, was amazing talk. Thank you. Who opted out VR class due to their complaint. That's right. So what we do is that the VR session is the voluntary session rather than the compulsory session. So we run VR by giving them slots so that students can, who are keen, they will book the slots, and who are interested, they will take part in the VR session. It is not mandatory. So those who have attended the VR and those who wear glasses, they have complained about the visual blurriness. But other than that, very few have a report about headaches, which is very minimal, very few number. Yeah.
In some cases, when we have also more students than headsets, we also give them the opportunity to have an augmented reality with a tablet. So actually, if some of the students feel nauseous or they have had like already 30 minutes and it's sometimes they can have nausea or blurring, or they just want to go for a break, they can swap and they can go into the augmented reality station. So these are interchangeable if you have any students that have no motion sickness or any other complaints like this.
Nikhil is asking which layer has blood supply. I think that's for you, Dr. Smilevska, referring to your demonstration of the model you were using before. So which layer has blood supply?
I don't understand what he means of layer. So yeah, the talk was about the gastrointestinal tract. So
you mean it is in mesentery layer? You mean between the two layers of the mesentery? They run in that.
I don't know what he means about layer.
I think we need that question specified a bit more clearer. So, okay. Let's see if any other questions. Yes. Anyone, don't be shy. This is a fantastic opportunity to ask our guest speakers any questions, address any of your concerns.
Feel free to ask any questions. We are happy to answer. Let us know.
Yeah, last Friday we actually participated in there was a course about VR educators, which gave very also nice advice how to set up a VR in your institutions. If you're interested, what would you need? This was very helpful to think if you need to implement and start a new project of VR teaching, what would you need? What infrastructures, what technical support, what hardware and software. So actually this reminds us of the path we've already been through with these last 2 years. So if any of you have any questions on this, we're happy to take these questions as well.
Yeah.
Oh, that's absolutely wonderful. Thank you for volunteering that. So please feel free to ask questions. This is a great opportunity to address any of your concerns. Ahmed is asking, did you think of incorporating clinical problems with another? Oops, can we go back to that one? George, there was another question before that. So let's go back. So, okay, Nikhil is asking.
Question.
Ahmed, okay, let's start with Ahmed's question.
Yes.
Thank you, Ahmed. Did you thought of incorporating clinical problems with anatomical structures? Yes, so it depends on the like kind of a different session. So what we are given a glimpse of it. So we give a like case sheets alongside, to aligned with the what topic we are covering. So after the VR, they will work on the worksheet aligned with the 3D organ pictures. Those kind of work we do run, but we didn't highlight it here. But thanks for asking though to share. Yeah.
Pedro is asking, have you noticed improvements in anatomical details using the new version of Oculus?
Absolutely, absolutely, yes. So when compared to Oculus Quest 2 with Meta Pro, we are currently using Meta Pro. So we see the difference in terms of the clarity and the visual feedback is good. Haptic feedback is amazing.
Yeah.
Yeah, and students have the glasses, they don't have any issues, which is really good. Yes.
So we've seen this
Changes,
is a significant improvement.
Yeah.
I would like to add
Thank you,
here
Pedro,
that
for this question.
the new edition, just to add to what Sharmila Dr. Rajendran kindly answered, we are releasing the new edition on desktop as we speak today. And we're only a short week or so away from releasing the new 3D Organon edition for virtual reality. And to answer Pedro's question, yes, also we have refactored the entire 3D Organon anatomy software applications from scratch, meaning that we have addressed issues, or we have actually enhanced performance visually in the models with more realistic models and so forth. So there has been considerable enhancement to the quality in the models, and that will become evident as people start obtaining access to the new edition being released. Is there, Oksana, is there any vascular variability in the program? Oksana is asking.
Know that I have seen. Maybe Theodoros will give us more information on that. Yeah, we all know that there are a lot of anatomical variations, and basically the vascular supply, also the biliary tree. So, but I think that this, like the classical anatomical books, covers the majority of the normal, what we call normal anatomical variations.
Victoria is asking, how does the integration of VR technology in clinical anatomy classes enhance student engagement and comprehension compared to traditional teaching methods? That's one question, and followed by a second twofold question. How often do you use VR? Every session, every other session, or just optional classes where you provided slots?
So thank you, Victoria, for your question. So to answer, how does the integration of VR technology in clinical anatomy classes enhance student engagement and comprehension compared to... So one thing we have to clear here, so we are not comparing with the traditional anatomy. So we want to go parallelly with the traditional anatomy. We just want to complement with the traditional learning. So in terms of the clinical anatomy sessions, so as it goes by layer, as Rumi has demonstrated, so it gives a clue, it gives an idea of understanding how deep the structures are, what layers they have to go through. And it's not just about students just using VR for 20 minutes or 30 minutes. We do ask questions, because now the VR, you can cast it to the screen. So where we ask one of the other student to discuss some of the questions we are given in the sheets. So that way we think we are definitely not as a complementing in terms of traditional. And how often do you use VR? As we mentioned before, so VR is every week a voluntary session. So we usually run different slots. We run 6 to 8 sessions So with the various slots, yeah. Is that clear, Victoria? Thank you.
Water that go through the GI tract daily, how much makes it out in the feces, primary absorption absorptive organ of the digestive system, and how to improve teaching and method on projection. These are questions that only definitely our guests can answer. So
What is a good?
So how to improve the teaching method on projector. So what we've shown here is like we've taken a video of a VR session when we explain, as I was running through the session when the video was going on. So the VR session is taken with the VR sets, and I think actually it loses a lot of quality when it's translated to video like this on a 2D dimension. So to answer your question, how would improve the teaching on a projector? I wouldn't project this to teach on this. How we teach is the students with the VR sets that are exploring this or guided by us or on their own after a session we've given them. So I think this will improve your teaching methods and the outcomes, because what we've had the feedback from the students is that basically they enjoy this vascular sessions because they're able to follow each of the branches to see the anastomosis, and they are actually perplexed and mesmerized and very nicely surprised of what they can obtain as a knowledge through the VR, especially in the vasculature. I can talk about the GI tract, but the vasculature in general.
And add to Rumi's thought, so we usually run the VR session for small group teaching. So we haven't tried for the large group. So, and also it worked really well for small group because you will have enough space to interact with the students, and students, they will interact each other. So you just project it cast it to the screen. So you give a monitor, two students can work together. That's how we are looking, well, like how inclusively you can promote the VR, VR in inclusive learning. So it depends on what you need, how you design. So of course, if you want to project it to be projected to screen, of course you could do it, but we haven't tried. And but you can cast it. You can cast it.
Or you can use the multi-user. So
yeah, that's the best option.
Yeah.
Go for the multi-user. So you will have you will have 10 students you can accommodate 10 students. That's the best way. You can interact, you can hear the voices. Yeah.
Let me just elaborate on the multi-user that you mentioned, the 3D Organon Medverse, otherwise referred to as the multi-user. It allows a professor to be able to create a virtual room within seconds. The process is very simple, very user-friendly, and host up to let's say up to 10 students, regardless of where they are, either for in-class sessions in a designated VR space or VR lab for in-class sessions, or even to allowing for a professor to conduct remote sessions, regardless of where the students are, across campus, at another campus, across the country, across the continent, or across the globe. This literally saved the day in salvaging, minimizing downtime in the hours that were allocated for teaching during the COVID pandemic, and now universities around the world are rapidly employing and designated VR labs where they're using the multi-user for their sessions. As I said, either in class or remote delivery of their sessions. It's an amazing 3D Organon communication platform, allowing just exactly that, just bridging that gap and allowing for real-time anatomy demonstration. So I do, as Dr. Rajendran said, sorry, I do recommend and urge our partners, our users of 3D Organon to take advantage of this great platform and to explore it. Any other questions? No? Not from the other platform either, no? Nathan is thanking our esteemed guest speakers for sharing their knowledge.
Thank you,
I
Nathan.
join him in that too, so it was very valuable. I think we've come to the end of the Q&A part. I can't see any more questions. So as we draw to a close, I want to express my sincere gratitude to our esteemed speakers, Dr. Sharmila Saran Rajendran and Dr. Rumyana Smilevska, for sharing their invaluable insights into the immersive world of VR in clinical anatomy teaching. Dr. Rajendran's expertise in anatomy and medical education has shed light on the transformative potential of virtual reality, while Dr. Smilevska's unique perspective as a surgeon and educator has surely enriched our understanding of the practical applications of VR technology. Your contributions, my dear and guest speakers, has not only inspired us, but you have also laid the groundwork for future advancements in medical education. For this, we thank you both sincerely. And what better way to conclude our discussion than by reflecting on the groundbreaking features of the new 3D Organon, from its blazing performance to its innovative organ mapping, explosion tool, the new 3D Organon assessment module soon to be with us, and much more. This cutting-edge technology empowers educators and learners alike to unlock their full potential. As we part ways, let us carry forward the spirit of innovation and collaboration that defines our medical education community. Together, we will continue to push the boundaries of knowledge and transform the landscape of healthcare education. So please visit us and explore how 3D Organon virtual reality with the absolutely breathtaking new 3D Organon is rapidly transforming standard anatomy teaching and learning, allowing both educators and students to visualize anatomy in an entirely new perspective. So from my heart, I wish to sincerely thank you all for your participation. And until we meet again, stay safe, stay well, and let us strive for excellence and embrace the possibilities of tomorrow. Thank you for the honor of being with us today, both to our guest speakers and our participants. Thank you. Take care and stay well.
Thank you, Theodore. Thank you, everyone. Thank you.
Thank you very much.
Thank you very much. It's nice to. It's a pleasure. Thank you.
An absolute pleasure and honor. Thank you.